So now let's start our presentation by our the structural heart fellows. We have 4 cases.
Textbook.
And if we can start with the first one with Melissa Moy. I know you're supposed to is here. Okay, great. So we have 4. It will happen. Everybody will go home with some goodies, which is the iPad system. But the one which will rate and the best one will go with even bigger than that, which is some MacBook Air.
Okay.
All good stuff. Now there are a lot of gifts there. Okay, then the
All right,
raffle, there are some other things, but okay. Melissa, tell us what you want to show us today.
All right. So my name is Melissa, coming from Toronto. I'll be presenting a case of TTVR in severe TR. So this is a 76-year-old, or was a 76-year-old Caucasian male who's referred to our structural heart clinic for NYHA class 3 symptoms. He particularly had ascites and significant peripheral edema despite an aggressive diuretic regimen. He had no prior visits to the emergency department. So he had a significant cardiac history, a familial dilated cardiomyopathy with an LVEF about 45 to 50%, sick sinus syndrome for which he was pacemaker dependent, had his first pacemaker placed in 1999, with subsequent generator change out in 2006 and 2013. Unfortunately suffered device infection for which he required a lead and a generator extraction in 2016, with subsequent implantation of a right-sided single-chamber pacemaker. Developed severe TR in 2020 with moderate RV dysfunction, and then suffered from cardiac cirrhosis from the RV dysfunction and severe TR, chronic AFib, hyperlipidemia, type 2 diabetes, and a TIA in August of 2020. He has baseline CKD with a creatinine about 1.9 to 2, and his medications on the right-hand side, you can see he was on a good dose of diuretics, furosemide 40 twice a day, spironolactone 75. He was a social smoker but quit at 25, and no alcohol or drug use. When we saw him in the clinic, his blood pressure was normal. He did have a systolic murmur reflective of severe TR, JVP up to the jaw, and at least 1+ peripheral edema. He had some hyponatremia, creatinine of 214 and Canadian values, EGFR of 35. NT-proBNP was elevated, and he had the chronic thrombocytopenia. Prior to seeing us, he had a right heart catheterization with RA pressures measuring at 11, V wave of 13, but only a mean PA of about 17, otherwise preserved cardiac output. And on coronary angiography, he had mild diffuse disease and kind of incidental finding of the RCA. So shown here is his baseline TEE. On the top, you have the RV inflow view, and then shortly on the right side here, you can see the transgastric view. But what we're seeing is a horizontal laying of his lead that's going in a posterior to anterior oblique position. We also see a dilated tricuspid annulus with a very large coaptation gap. On the 3D NPR, we can see the same thing. It's also impinging the posterior leaflet, preventing it from actually coapting. And then we can see the large jet in the kind of posterior septal area as well as in the central region. So given this, we knew he was not a TEER candidate, and so we went ahead and ordered a CT scan for him to begin planning for TTVR. Shown here is basically his heart modeled for the large Cree valve stent. We can see his trigone to trigone diameter, which is the annulus, which is about 54 millimeters. The perimeter derived diameter was about 49 to 51, and his right IJ was about 7.4. So as mentioned, because of the large coaptation gap, the PPM lead across the annulus and impinging the lateral leaflet, he was not considered a TEER candidate. He was also not suitable for orthotopic TTVR when he was screened at the time due to a large annulus, and particularly for EVOKE, as well as the RV dysfunction. He also screen failed for trick valve, which is another heterotopic TTVR, and so he's accepted for compassionate use Cree valve, which is essentially like a dual coaptation device with a SVC stent placement and a spacer within the tricuspid valve. This was first tested in vivo in 2019. This is a pig model that was presented at TBT during the time, whereby the coaptation device sits within the orifice of the tricuspid valve. The native leaflets are then able to seal against the outer skirt of the coaptation device, thereby preventing MR. And the device also has this valve inherent within the coaptation valve itself that allows still for diastolic flow during diastole. And again, the SVC stents sits to essentially stabilize. You're not affecting the right atrium, and you're not affecting the the tricuspid valve itself. So the first trial was presented in Tandem 1, first-in-human trial, that was also presented at TBT in June of 2023. This was done, I believe, in Poland or the UK. This is only 9 patients, 89% were female, but they did want to look at safety as well as secondary outcomes, particularly their symptoms and reduction in TR. Their plan is to look at both up to 24 months, but of the 6 months data that they were able to present at TBT, patients who had massive or torrential TR at the 6-month mark were basically only mild to moderate. Their NYHA class symptoms also improved, as did their 6-minute walk test and KCCQ-12. So in our particular patient, the team first used the Agilis catheter, demonstrated here on the left, to essentially prove that the lead that was placed about 7 years ago could still be slightly adjusted such that the spacer could be placed within the posterior septal area where we would target the jet. Subsequently, a marker pigtail was then advanced into the right ventricle to perform angiography. Unfortunately, what happened was while the pigtail marker was being pulled out, unfortunately, despite the lead being there for 7 years, the lead was dislodged. And as I mentioned earlier, the patient is in fact pacemaker dependent. So of course, the team immediately transcutaneously paced him. They put a temporary wire, a balloon-tipped pacing wire within the left femoral artery into the left ventricular apex. And using an end snare, they were able to snare the RV lead down into the IVC and then focus their attention back on the tricuspid valve. So here we see the balloon-tipped pacemaker in the left ventricle. And then over here, we're seeing that we're beginning now to centralize the CreValve device within the tricuspid valve. The SVC stent has already been placed. Immediately after, we, of course, called our EP colleagues, and now that the lead was completely out of the way, they were able to use a deflectable Medtronic sheath here to be able to begin placement of the new RV lead that's going to be placed posterior to the CreValve itself. And despite all of this, we were able to at least reduce the severe TR to now about mild to moderate. Despite the new lead being placed, it also did not affect the actual valve itself. And again, the final residual amount of TR was more so anterior septal and only mild to moderate. So just the final picture of what everything he's had and all the devices is old pacemaker with a dislodged, abandoned old lead in the IVC, which was just left, the new pacemaker placed by EP, the new RV lead placed posterior to the CreValve, and the stent of the SVC in the CreValve apparatus. So in follow-up, he was seen in structural heart clinic about 1 month after. He had significant improvement in his symptoms, functioning at NYHA class 2, improvement in exercise tolerance, no heart failure exacerbations, and a follow-up transthoracic echo showed that he had a stable CreValve with a mean gradient of 1 millimeters of mercury and moderate TR only. So in summary, overall, the CreValve is a palliative option for patients with severe TR that are not candidates for TEER or their orthotopic devices. Despite a lead being as old as it was, about 7 years, lead dislodgement can happen, so it's important to plan for them and navigate appropriately. Even with this CreValve there, if a new lead is needed, it can still be done. Thank you.
Thank you. Okay, so we are going to grade, and if any question for her?
So basically, the patient got a lead extraction for free during the procedure. My question is 2 things. Did you consider doing a lead extraction before? It looks like CoreValve, the advantages is you can still do the device with a lead in it.
Yes.
Most of the tricuspid screen failure happens due to 2 reasons. One, it's a super big, the sizes don't cover, or you actually have a CIED, the cardiac implantable electric devices, which is a contraindication, or you can't do it. So did you actually consider removing the lead? All the patients dependent, there's some leadless and other technologies. And second, what is your anticoagulation treatment after this?
Right, so I think the lead extraction was discussed, but given the fact that he's already had so many changeouts and then the lead infection and all that stuff already, we kind of just thought that that was not a good idea for him. So that's why we began the TTVR screening. So that was the main reason why. And then in regards to anticoagulation, we switched him from edoxaban to apixaban on follow-up.
Thank you.
Yeah, no problem.
Okay.
Thank you.
All right. So second presentation by Wael Abusina. We'll talk about self-expandable valve embolization.
Hello, everyone. Thank
Great.
you for this symposium. My name is Wael. I'm from Georgetown University, Washington Hospital Center in DC. So very detailed history and physical examination, 77 years old male with severe aortic stenosis and need TAVR. As everyone knows, we need to do the pre-procedure planning. Ejection fraction is 65. Annulus is perimeter is 82 millimeter, so he can accommodate evolute at 29 millimeter. We can see the angiogram of the lower extremities. They looks good. Minimum calcification, some tortuosity on the left side. Severely calcified aortic valve with the extension to the LVOT, I would say mild to moderate. So at the TAVR day, they brought patient to the cath. So the temporary pace is in place. We have the pigtail. We can see the angiogram of the aortic. I would say it like type 2 aortic arch. Everything goes well. We can see the severe calcification of the aortic valve. Placement of the sentinel device. Very easy, simple from the radial axis. We did the pre-deployment valvuloplasty with the balloon 20 millimeter at 20 atmosphere pressure. Before that, we advanced also the sapphire wire. So we prepared the valve. Now it's the time we delivered the valve to the area of the aortic valve. The plan was to do like commercial alignment with the 3 millimeter depth plan. From the left side and the right side looks good. And after deployment or during the deployment of the valve is popped up, and now as we see it's not in the right position. So now we have the valve in ascending aorta, which shouldn't be there, should be down a little bit in the aortic valve area. As a maybe first year attending, I don't recommend to panic, just relax, take a deep breath. Everyone will panic if you panic. If you have 30 seconds sneak, maybe check Twitter, YouTube to figure out how do they do that, because I don't think you're gonna see this in your training. So this is the 29 millimeter evolute, now is in the ascending aorta. So just let's take few slides to review what people say about the embolization or migration of the aortic valve, what's the percentage. So it's very rare. Partner 2, 3, and SOAR TVI trial, it was almost 0%. And the TRAVEL registry, which is a trans-heart aortic valve embolization and migration registry, so this registry only for those complications, it's 0.9%, less than 1%. Recent study, it was done in Charity Hospital in Berlin, Germany. So they reviewed all TAVR they did since 2009, about 3,700. They only had the migration, 54 cases migrated, and 46 from these cases was managed like percutaneously. Interestingly, the most common type of the valve who has this complication was evolute. Sapien was very low despite the high number they did. So they find like 40% it's pop up. So during the deployment of the valve, just the valve go up and went into the ascending or descending aorta. 20% it was incomplete release from the delivery system. So there is let's say the valve was stuck in delivery system. And about 13% embolization during post-dilation. When they did the post-dilation, the valve moved from its position. 80% it goes to the ascending aorta. Okay, when it comes to the causes and treatment, so you need to manage that, right? When you have this situation happen to you, so you need to ask for help or you do it by yourself. So when it comes to the causes, we can divide it to either the cause could be pre-procedure or procedural. The pre-procedure most of the time is just anatomy, we have horizontal aorta, or we sizing error, bicuspid aortic valve, or lack of calcification. So the valve doesn't have calcification to catch to it. The procedure calcification can be divided in two types. Could be the issue during the positioning or issue during the deployment, failure of pacing can cause also a migration or embolization, or during that post-dilation, or during the disengagement of delivery system, there is no full disengagement, and when you pull the delivery system, you pull the valve with you. So this is the first scenario, like the location of the valves that happen to you. So either it goes to the ascending aorta or descending, or goes inside the LV, or just deep inside, but still catching at the aorta area. So we know, first thing, don't panic. Second thing, you need to be aware of the snaring device. So you grab one of them from the shelves and use it. So you need to snare that device. This is number one. Number two, make sure, exclude any, especially if the descending or ascending aorta, there is no occlusion of major arteries. And number three, try to reposition. If you were able to put it back, that's good. If not, make sure you anchor it either in the ascending or descending aorta, and you can use inflation. And then continue your procedure. You need to finish, because you start with TAVR, you need to finish with TAVR and put the valve there. If it went to the LV, try to snare it, but most likely this patient is going to go to the OR. So go back to our patient. So that's what we did exactly. We went look Twitter, we find out this, go back to the patient, we snare the aortic valve, make sure, and then we exclude there was no major like arteries are occluded. And make sure that, and now after you like position the valve, make sure that it's in the right position and fixed and not movable, because now you're starting the second TAVR. And we are delivering the second TAVR, you're gonna put a lot of pressure on the old valve, right? And this is can might push the valve and may cause harm to the aorta, because still around the aortic wall. And that's what we did. So we bring this gooseneck, the snare, we snare it, and now we are delivering the other 29 millimeter evolute. And if you see in the beginning of maybe the video, when you need to snare, push, pull, and then pushing the delivery system, because you need to do both technique together so it doesn't move. So luckily we were able to deliver the second valve in the right position. As you see, I think has better position. And now it's in the right one compared to the first valve. We did the valvoplasty, the first one, using 24 balloon at 24 atmosphere pressure. Looks okay. We used other balloon, 26 millimeter at 26 atmosphere pressure. And the final result on the left side, and we were happy. Now we have two valves. Snare system was removed, and everything is good. So now we have this patient has two valves, he's stable, he's gonna go home. I think I recommend closer observation, repeat CT in 1 month, make sure there is no migration. So now there is a potential complication. Now you have two valves. This is like an abnormal situation, right? So the possible complication, either subclinical thrombosis, infection, could migrate through the wall and cause infection. And during 6 months follow-up, the patient came back with shortness of breath, he had some fever, and he was not doing well with a lot of respiratory issues. So we repeated CT, and as you see in the CT here, there's some dilation very close to the valve, and this is a mycotic aortic aneurysm. It's dilation in the aortic wall because of the infection at that site, and this is new, and this is because of the valve. When compared to the old one, he didn't have any dilation. So the patient then, he went surgery, he had Bentall surgery. They changed the aortic root, aortic valve, and also aortic arch with re-implantation of the coronaries, and he's doing well after 1 year. And that's my case, thank you.
Okay, any questions?
Why do you think the valve embolized?
Sorry?
Why do you think the valve embolized?
I'm not sure. It's popped up during the procedure. I was thinking maybe the LVOT calcification, and we did the pre-deployment valvoplasty, could make it wider. That's the reason. But
And the second valve was the same size or different?
same size, 29.
Thank you.
Thanks.
You have considered SAPIEN second time, or like you are comfortable going with Evolute again?
Sorry?
Like the second time when you saw your 29 Evolute didn't like hold in the place despite given a lot of calcium over there. Would you
Yeah.
have considered like another valve platform, or like you were comfortable going with Evolute only?
So my attending was comfortable doing the same like the same type of the valve, because they have more experience with that. So, yeah.
And do you consider some anticoagulation afterwards, or like you just left on antiplatelet agent?
No, just like the normal
Okay.
anti-thrombotic.
No, great case. Thank you.
Okay. Now we have the third presentation by Chavez Ciudad de Mexico. From presenter is Heron Mendez Sanchez. Okay. All right.
Good afternoon. My name is Aaron Mendez. I'm interventional cardiology fellow, and I'm from Mexico City. This case is about left main coronary artery occlusion after TEVR in a patient with massive valvular calcium. So here's the case. He's a 70 years old man with hypertension, treatment with enalapril. His symptoms began with edema of lower extremities as well as dyspnea that progressed to minimal force, and in the last month with chest pain was aided. That increased with the fore and decreased at the west. So, as systolic murmur in the aortic focus was identified, so an echo was performed in this patient, which documented severe aortic stenosis with a valve area of 0.42, mean gradient of 65, velocity of more than 5 meters per second, as well as LVEF of 35% with generalized hypokinesia. We can see here the amount of calcium in the valve and diagnostic. Also, we perform an angiograph and coronary angiography, and it doesn't have any lesion, any stenosis. It was normal. So, TEVR is proposed, an average score of 2 or 3.2%, STS score almost 2%, and so an angiotomography was performed, which documented severe annular calcium of almost 7,000 Agatston units, with fusion of the right and posterior left ventricular outflow tract, also with moderate calcification, so much nodules of calcium, but the height of right coronary ostium at 10 millimeters from the aortic annulus, and also left coronary ostium at 14 millimeters. So at this point, it seems that there's not going to be any problem about the left main, considering the height. An aortic annulus of 26.5 millimeters by area, and also 27.2 by perimeter. Finally, TEVR was performed. We used a transvenous pacemaker, while femoral approaches were selected, and also femoral with preclosure with a ProGlide device. We advanced a Safari guidewire, and then we decided to predilate with a 20 balloon because of the amount of calcium. And then an Edwards Sapiens 29 millimeters was advanced to aortic annulus, and it was delivered. At this point, everything was okay. In control angiography, we had the adequate position of the valve, no paravalvular leaks. We had the echo, no paravalvular leaks, and a peak-to-peak gradient of 2 was measured. So everything was like a success procedure, but the flow towards the right coronary artery was adequate. However, the flow towards the left main was decreased. Then the patient had some hemodynamic impairment, chest pain, hypotension, tachycardia. And we can see here how it's the commissural alignment. So here we can see in this point calcium nodule just near the left main, but the valve expanded pretty well at this point. This was the first injection. We see the right coronary was okay, but the left main was decreased the flow. Yes, it's well, we can see here the image, and we can see the valve because of the amount of calcium. It was like so difficult to dilate the valve, but at the end the valve was okay. And well, this is the left main. It should be this way. Well, everything was it burst. So the osteum of left main was cannulated with a guide catheter, observing a subocclusive lesion of this osteum, and also the body of the left main is right here. We cannulated through the cells, and we advanced a coronary guidewire to the anterior descending artery, and immediately a 3 balloon was advanced to the osteum, and it was pre-dilated. With adequate expansion, with recovery of anterograde flow, we can see here. But we still see some stenosis from the osteum to the body of the left main. And here's the balloon. There was no problem with the predilation. And also we advanced IUs. Likewise, an intracorneal ultrasound proof was advanced, obtained the following measurements. It was after the predilation, vascular area of almost 20 millimeters, minimum diameter of 4.8 millimeters, maximum of 5.3. And then we decided to advance the stent, 4.5 stent, and after that we advanced again the IVUS, because we saw some stent under expansion in the IVUS. So stent expansion was optimized with 5 balloon and no compliant balloon. This was the area of more stenosis. It was after predilation. Well, angiography with luminal and flow gain, that was after the stenting. I was again advanced, now documenting an area of almost 23 millimeters, and better stent expansion. Patient was recovered, and there was no chest pain, and the pressure was okay. So it is decided to conclude the procedure. Femoral access closure was performed with ProGlide with no complications. Patient with adequate hemodynamic status and good clinical evolution. So he was discharged 48 hours later with no complication. And we can see here the last image of the stenting since the osteum to the body of the left main. And well, I decided to present this case because of the calcification. Sometimes we don't consider the Agatston unit. This patient was, everything was okay, the valve was okay expanded, but there was almost 7,000 of Agatston units there in Mexico City, my hospital, in the Institute of National Cardiology. We are working in a study about the number of Agatston units, less and more than 3,000 of these units, and we can see so many complications after 3,000 of units of Agatston, because in worldwide the literature is less than 1% the closure of left main. Thank you.
Okay. Any question? So now, could you have predicted that left main occlusion with the height of the left main before it started the?
If we predict
Predicted the left main occlusion on the CT analysis at the time of the
yes,
tower?
well, the height was 14 millimeters. It was okay. We thought there was not going to be problem about the occlusion. We wasn't hope occlusion of left main, but we saw there was a calcium nodule just behind the left main. So that was a point of consideration. But about the height, it was okay. Yes, at the beginning.
Any other questions?
Do you remember the size of the root as well? The sinuses and the height and everything?
Excuse me?
Do you remember what the size of the aortic root was as well, in terms of the sinus size or the height?
The sinus of the Valsalva.
Yeah, yes, it was, the diameter was 31 millimeters. 31.
Yes, sure.
So great presentation.
Thank you.
Just one question. So do you think using a 26 valve here would actually give you better expansion instead of a 29? Because
yeah.
giving a undersized, fully expanded valve is better for degeneration. I mean, you tackled this complication really well, but your valve is very underexpanded, sort of,
Sure.
deformed and underexpanded.
Yes. Also, the area was, we thought about 26. Maybe it was better 26, not 29. And retrospective, it was too aggressive to select a 29. Well, because of the calcium, we moved all the amount of calcium that was just behind, just below the left main. And we approached it to the left main and we are close. It could be like some predictive. Yeah.
Okay, thank you. All right, we got to the fourth one, which is from Sinai by Richard Tanner, the Tower Double Trouble. AK, you can come here about the raffle you'll do, because while we'll decide about
Thank you for giving me, as Dr. Sharma said, my name is Richard Tanner. I'm one of the structural fellows here. Thank you for giving me this opportunity to present an interesting case we did here in Sinai last week. So this case is an 81-year-old female who had worsening shortness of breath over the past 6 months. At the time of presentation, she was NYHA class 3. She had past medical history, most notable for a bioprosthetic AVR in 2009. This was a 23mm mitral flow valve. She also had hypertension, hyperlipidemia, anemia, and non-obstructive coronary disease on a recent CAT. She had the diagnosis of severe aortic stenosis made at an outside hospital. They had found a peak velocity of 4.2 and an aortic valve area of 0.67 with a mean gradient of 40 millimeters of mercury. Ejection fraction was preserved at 60%, and her STS score risk of mortality was estimated at 7.5%. At that other hospital, she declined surgical aortic valve repair, and the heart team there felt she was too high risk for valve and valve due to the risk of coronary obstruction. So she was referred to us. So for the case planning, we started with the Dr. BAPS app for the aortic valve and valve. And on the first page of this, you see a very important thing highlighted, and that's that the MitraFlow has externally mounted leaflets. And for the 23mm valve that this patient had in situ, the true internal diameter was 19 millimeters, and the recommendation was a 20 or a 23mm S3 Ultra. On CT, the transfemoral access was favorable with no significant iliofemoral disease. Looking closer at the annulus, the average diameter at the annulus was 19.9 with a valve area of 313 and a perimeter of 62.8. The LVOT was marginally larger with an LVOT area of 325. So the sinus of Valsalva in this case, the right was 24.5, left was 25.1. The left coronary and right coronary were both low. The left measured 5.1 millimeters height, the right 7.8 millimeters. And the virtual valve to ST junction distance on the left side was 2.3 and 2.9 on the left. And again, looking at this virtual valve to coronary distance on the right, it was very small, 2.1, and on the left, 2.3. So she was reviewed by our cardiothoracic team here in Sinai as well. She was adamant, flat out, refusing to consider open heart surgery, and I guess she had good experience of it previous. However, she was keen to have intervention given her symptom burden. So she was discussed at our weekly heart team meeting. She was deemed to be a high-risk TAVR case, small annulus, and at very high risk of coronary obstruction. And it was felt that either a double basilica or left main and RCA protection would be needed with snorkel stenting. So our plan before the case was to do transfemoral TAVI under general anesthesia with transesophageal guidance using a 20 millimeter Sapien S3 Ultra Resilia, protection of the left main with wire and stent, and on the right side, wire and stent protection as well. We did not go for basilica given the perceived procedure complexity, the time involved, and a lack of commissural alignment with the 20 millimeter valve. And due to particularly access issues, we did not plan on using cerebral embolic protection. So on the setup, we did an aortogram, and you can see in particular, the height of the prosthetic leaflet of the mitral flow, which can often be up to 13 millimeters, and it's extending. You can kind of get an idea that it looks like it's extending above the height of the coronary. And then we did selective angiography, and you can see that there was widely patent vessels, a bit of mild disease in the proximal RCA. So this is our setup shot. So we had a VL35 guide coming from the right radial artery with a guide extension, wire and stent in the LAD. And we had an AL1 guide coming from the left femoral artery, again with guide extension, wire and stent ready. Then we positioned our Sapien valve across the aortic valve, and we were ready to deploy. So, and under rapid RV pacing, we deployed our valve. And immediately following this, we pulled the right stent back, this was a Megatron 3524 stent, and pulled it back and deployed it. In the center image, you can get an idea of this white line sign of the cusp, which you can see looks like it's got impending coronary obstruction of the left main. Hence, we went ahead and deployed the left main stent also. And thankfully, she was quite stable throughout all this. And we did angiogram, which confirmed the right stent was widely patent, as was the left stent. And final aortogram confirmed that the valve was well positioned, that there was no significant paravalvular leak or aortic regurgitation. Furthermore, on transesophageal echo, you could see that there was no paravalvular leak, significant aortic regurgitation, and the transvalvular gradient was about 2.8 meters per second. So to the clinical outcome of this case, so the procedure took about 1 hour 15 minutes. That was from the first access to the final aortogram. This lady thankfully did very well, and she was discharged home the next day. And she went directly home. She did not need any rehab. The discharge echo, she had a transvalvular gradient of 3.1 meters per second, no paravalvular leak, no aortic regurgitation, and an effective RF surface area of 1.1 centimeter squared, and she had no conduction issues. And we followed up 1 week later over the phone, Dr. Sharma did, and she is delighted with her procedure, I'm happy to say. So just some points about this case. This is the first case we had done like this here in Sinai, and we found that double snorkel stenting is a feasible option when both the left main and right coronary are at risk of coronary obstruction. It's an alternative and potentially more favorable option for certain centers in particular than double basilica in terms of procedure complexity, teachability, time requirement, and you've less concerns about commissural alignment with the valve you've cut. However, snorkel stenting has the potential downsides of stent thrombosis, challenges in coronary reaccess, and limited data on long-term outcomes, particularly in a case of double snorkel stenting. Thank you for listening. I'd be happy to take any questions.
Any questions?
What kind of DAP strategy would you use in these patients? Because I imagine their chronic risk
So I guess at the moment, for our standard would be aspirin for life and Plavix for 3 months. In this lady, we plan to continue the DAPT for at least a year.
Protocol is if you actually have someone with a left main risk obstruction and you're using a wire protection or a stent, they get loaded with the P2Y12 inhibitor ahead of time, and then we continue DAP at least for a year. And every one of these patients get 30-day post-follow-up CT scan.
Yeah, so question will be, so if this patient comes back with a restenosis, I actually have done the mid-LED stenting. They did the chimney stent at other institution. There was a 90, at that time, pre-tower, they left 80-90% mid-LED, and patient came back with a non-QMI, non-STEMI, and then I had to go through that chimney stent. It was okay, actually. I thought it will be very difficult. Remember the case of the, through the chimney stent going into the mid-LED, and we put a stent, yes, required guideliner, which happens. Hopefully this patient never developed the RCA stenosis. The RCA will be very, very difficult, but we'll see when that time comes. But this, as I said, it was the first case of this type at Sinai. It had been described, but this, rather than doing a basilica, which is a very complex procedure, all the new devices are coming, which will be simpler. This was the great patient actually looked around. Even we, I thought one time, but not going to do it. But after heart team discussion, we all just kind of gathered the courage and said, let's do it. Happened to some of the one, it's a patient also was a very prominent person, mother of a very prominent political person, and so. So key is that basically the tough cases, as long as you have planned properly, they can be done, and literature helps you going through various procedures, techniques point of view. Okay, with that note, Richard, thank you.
Thank you.
Okay, while we